Crime, Chelsea Peltier and Margot Parks. And so the three of us get together with Bree and Rachel every year and organize the speaker list for the upcoming academic year. So having said that, then it is my great pleasure today to be introducing to you Dr. Dave Snadden. Dr. Snadden is a family doctor. He did his medical training at the University of Dundee in Scotland, where he did part of his training and had a focus and interest in rural medicine. He then went on to hold several positions in academia and complete graduate work in the area of medical education. And I first met Dave, and he first came to UNBC in 2003 as the Regional Associate Dean for the Northern Medical Program. So he was the first Regional Associate Dean for the Northern Medical Program, which was part of the Distributed Medical Education Program at UBC, which at the time was completely unique in Canada, and it has become an example of successful distributed medical education, not only in BC and Canada, but around the world. Following 2 terms, is that right, Dave? 2 terms as the Regional Associate Dean, he went on to become the Executive Associate Dean for all of the Faculty of Medicine. And following that term, he was given the the chair, UBC chair in rural health, which was funded through the Rural Doctors of British Columbia, through the Doctors of BC and the Ministry of Health. And so today he's going to share with us some of the work that he's done in this role, in this research role. So Dave was one of my mentors and is the reason that I'm here at the NMP. And so I'm really excited, Dave, to hear about the work that you've been doing over the last couple of years.
Great. So thank you very much, Sarah, and welcome everybody. See if we can get the technology to work. Oh, look at that. So looking at the list of people, I think I know a lot of you on the list that are here today. And for those that I don't know, welcome, and I hope to get to know you over the next little while. We have some time together, and I'd like to keep this relatively informal. And so as I go through and talk about what we're doing, please feel free to ask questions. And I'm wondering the best way to do this, Sarah, would it be for people to flag up on chat they want to ask a question, and you can let me know?
Absolutely, I can for sure do that. So I'll keep an eye on the chat.
And
you don't mind, yeah, and you don't mind to interrupt you.
And I noticed from the list that we do have Erica Belanger and Stuart Johnson on the line as well. So they're part of the team I'm part of. Stuart leads it, and Erica is the research analyst in this. So I'm going to ask them to chip in if I say anything inappropriate that they don't agree with, and also some of the parts when they may have better information than I do. So let's get going, and there's the team. So if you don't know what Erica and Stuart look like, that's what they look like. If you don't know what I look like, I don't look like that anymore. And Crystal hasn't been able to join us today. As ever, we have no disclosures around conflicts of interest to make. So I thought for all of you, we should probably give you some context around rural activities within British Columbia. And this comes from the perspective of particularly the physician side of healthcare. So the Rural Coordination Centre British Columbia, if you haven't heard of it, is an organisation which is funded by the Joint Standing Committee on Rural Issues. The Joint Standing Committee is a collaborative committee between the Doctors of BC and the Ministry of Health, and it has funding which comes through the Physician Masters Agreement. It's negotiated funding to support rural programs. And the Rural Coordination Centre of BC is funded by the Joint Standing Committee and provides a lot of help for rural practitioners and support systems and funding to help rural health across all the rural areas of British Columbia. So these are two critical organizations in the support, delivery, and advocacy of rural health in BC. So a few years ago, I don't know if it was your idea, Stuart, that we should go and visit all the communities in British Columbia, but this idea was taken from the rural docs to the Joint Standing Committee and said, look, it's about time we got out to the communities and found out what was going on there and talked to them. And so they funded this program over 3 years, and it will be extended because of the pandemic. And what they agreed should be done is that all 201 rural subsidiary agreement communities, and I'll come to that, would be visited. And that includes all the Indigenous communities as well as the non-Indigenous ones. A rural subsidiary agreement community is one that falls under the auspices of what we call the rural subsidiary agreement. And this is an agreement to fund rural communities in terms of their remoteness and their distance from services. This is primarily funding that supports physician activities, provides a lot of the incentives to deal with some of the recruitment and retention issues in rural areas. And the degree of funding they get actually depends on the size of the community. The smaller and the more remote, the more support they get. The purpose of these visits was to hear directly from the community members about healthcare and what they were thinking about it. And the purpose of gathering the data, apart from building relationships between the Joint Standing Committee and rural health providers, and particularly with building relationships directly on the ground, was also to advocate for policy change and program development. So part of the initial thinking was, are these programs working? And these are the programs delivered through the JSC and the RCCBC, or do we need to change them? And I think what you'll see is that we've evolved from that as we've run the project. So at this point, we've visited half the communities, and we've had 359 interviews within communities. Some of these are one-on-one, and some of them are with groups up to 10 or 12 people. So you can imagine that this is over 1,000 people at a very rough count. Here's so far the map of where we have visited communities. You can see here the green ones have been done, the orange ones are in planning, and the yellow ones, we don't have any services yet, and blue are still to be done. And the ones around Hudson's Hope and Big White have actually been, these are the first ones done post-pandemic, and they have now been visited virtually. It's not the same in any manner or means. So these are just the contextual things around what we're doing here. So when you're developing something like this, you always think about, well, what's our methodological framework? And so I'll just deal with the first bullet point here, which was using an adapted version of Charles Boland's partnership Pentagon model. Now, he worked for the World Health Organization and produced a paper in 2000 called Towards Unity for Health, which was a position paper around how could we better engage with communities and find ways to move the health agenda on and improve systems within these communities. Is there another way we could do this? Now, one of the reasons we chose this framework is that the RCCBC has used this framework in a lot of its engagement practices in the last few years, and it's a way of bringing all different sectors together. So this is Boland's original model, and you can see that what he has here is an idea that try and get together the health managers, the policymakers, the health professionals, the communities, and the academic student institutions, bring them together as a whole and get them in the same room, and then begin the conversation about how can we improve services here. So one of the philosophical underpinnings of the site visit program has been to try and bring together the different perspectives in a community to help them work together so we get a collective idea of what's happening within the communities. The RCCBC's work on this has been modified over time. This is what it looks like now. Now, locally in British Columbia and bits of Canada, I'll just go back this slide. This is called the pentagram model because it runs off the tongue better than pentagon, which is how Bolin originally described it. And now we've got this thing, which has got 6 sides and is now known as the pentagram plus. What's been added in here is the non-profits and the business interests. And what we found on the site visits is that, you know, those of you working in rural health will know every community is unique. They're all different. And therefore, the groups that function and work in a community are all different. And therefore, the sectors that we try to get together at each of these site visits depends entirely on where the site is and what the makeup is there. So in some of them, we might have all of these people there. And in others, I'm thinking of some of the very remote First Nations communities, we have one group because there is only one group. And so these frameworks are not rigid. They are flexible, and they're just an idea about how is it we can bring everybody together and think through and get the real perspectives of this community. So that's one of the theoretical frameworks that we have used. Any questions about this at this point? Feel free to, if something's puzzling you, to ask. Nothing on chat so far. Okay. The other things we have been thinking about, or the other things that have happened, is the process is iterative. So although we're visiting communities now, we learn as we go along, we adapt what we do as we go along, and we see this in the future as going back again. I think the idea of going in to do community development, just dropping in, and then never speaking to anybody again, just doesn't make sense. We're trying to build relationships for change in the long term. The other thing we've done is added, again, one of the philosophical approaches of the RCCBC, which is to focus on appreciative inquiry. In other words, to look for strengths, to look for successes. And as we were thinking through what kind of things do we want to speak to people about, we thought the appreciative inquiry approach would be an important one to build into it. Although we do ask for challenges, but we also want to look at the positive as well. So again, we've kind of modified that theoretical framework to fit the context in which we're working. And I thought since you're a whole bunch of researchers and people, we should throw in some big words. I thought we should just mention the ontology and the epistemology. These are complex terms that I struggle to articulate at times, and there are people in this seminar who know them way better than me. But one of them being the philosophy of being. Everybody lives in, you get into multiple realities and lived experiences. So one of the things we are thinking about in this research is how do we get a feel for those multiple different perspectives through people's lived experiences and how they work with each other. And the other one, the epistemology, is about the philosophy of knowing. And this would mean that the data we gathered should thoroughly reflect those perspectives and be contextually relevant, because knowledge is something, particularly in small communities, it's held in those communities and may well be related to their contexts and be unique. So we wanted to make sure that we understood as much as we could the different perspectives of the different people and the different contexts. So I just put those big words in there because I thought we should, but I don't, as I say, Martha and Erin, you can correct me if I've got them wrong.
Dave, I think there's just one question in the chat about the model.
Yeah, I can't see the chat.
Oh, I can read it to you here.
Yeah.
So the question is was the MCFD included as well? And I think this is reference to the model.
Yeah. So can somebody explain what MCFD is?
MCFD, I couldn't do the translation for you.
Ministry of Children and Family Development.
Oh, thanks,
right.
Rachel.
So if you look at policymakers, that would include government. And so although we're visiting small communities, we would be speaking to, perhaps if we can, to people who are involved in social work. We speak to mayors, and at a different level, the Ministry of Children and Family Development's government policy, we do feed back to them. So this is not an exhaustive list, particularly when you think this particular one here, which is who RCCBC tries to engage with, is much more comprehensive than what we would try to engage with in a small community. This is to give you an idea of anything goes. So Ministry of Child and Family Development could easily fit within the policymaker banner here. So it's a good question, and thank you for raising that. And so this is not by any means a complete list. You could always keep adding to it. And the most important thing about this is not the idea of who's in, who's out. It's the framework of thinking when we're trying to bring people together to make health systems change. Who do we need in the room to get a sense of all the different views in order to be able to move things forward? I hope that answers the question. Okay, so the next part of this story was, okay, so we're going to go and visit all these communities. How are we going to do this? And an opportunity seemed to arise as we thought about it, that, well, yeah, we can go and visit them, but what can we get out of this? And should we now be thinking about formulating this as a formal research project and actually gathering interview data as we go around the communities? So we, Crystal and Erica, and with Stuart and myself, in discussion with them, prepared a research ethics board proposal, which went to the UBC Behavioural Research Board, and they harmonised with all the health authorities. And this was a couple of years ago, and I must say that although it's, as you all know, these are complex things to get together, it actually went through the ethics process extremely quickly, and the whole of that system worked well. The real problem was getting operational approval from the health authorities, which can be incredibly slow, and certainly needed a few conversations with people. And eventually that also came through. And one of the things for you to remember is that the operational approval is nothing to do with ethics, and ethics is all about protecting patients and these things. The operational approval is how much disruption you're going to cause to their day-to-day working, and are you going to be taking essential frontline staff away and taking up time with them? And so that's the bit that if you are thinking of research projects on your own and you're going to have harmonized approval, ethics will come through quickly. It'll take time to get the operational approval. And the reason we needed that was because we were actually going to be in hospitals and health authority-owned clinics and be speaking to people who are health authority employees. And we also followed the ownership, control, and access and possession principles which are out there. So this is still in the ethics. Now, the reason I'm kind of laboring this a little bit, it's been a very important framework for us. We've been gathering huge amounts of data in different communities right across the province. And it's been very important, I think, for those participants to know that we were working within an ethical framework, that their identity would be protected, and that the information would be anonymized. And so this gives you a sense of how, or some of the promises that we made and some of the things that we do in order to follow these ethical principles. So everything is anonymized and aggregated, so you can't identify as an external person when we're putting reports out where stuff comes from. Everyone has a consent form to sign, so each participant signs consent forms, and they also get information about the project. We are audio recording all the interviews, and the transcriptions are sent to participants for their review and approval. So as soon as we get the transcripts back, they go back to the people. And in all their interviews we've done, remember we've got like 1,000 people, and we've had one person withdraw a transcript. And I actually did that interview, and I am not surprised they withdrew that transcript, because some of the content of that transcript was a bit concerning. Then all the transcripts are held in vivo, which allows us to handle this amount of data, and then they're coded. And Erica is, I'll maybe prepare you for this, Erica. I don't know if Erica is going to be able to speak, but if she can, then we might ask her how she actually has gone through some of the coding. So is that possible, Bree, for us to give Erica? Oh, there she is there. Good.
Yes, I'm going to put Erica, Stu, and Crystal all as panelists so that they can chime in if you need them.
Good. And then the other things we've been doing is reporting back. And Erica and Crystal have been working very hard to make sure that we report back to the Joint Standing Committee on a 6-monthly basis what we're finding, and we give community feedback reports. And I'll come back to these bits in a little minute or two. So just to summarize this ethics bit, it's all voluntary. People can withdraw their consent. We really ensure confidentiality is there, and we protect the identity of participants. And like many of you, if you've been involved in gathering qualitative data from rural areas, that they're so seldom visited in a way which is asking them what they think and what their health services are like and what's going well, that one of our great challenges is often to get the conversations to stop. People are excited to talk and all these other things, and it's absolutely fantastic. And therefore, we need to make sure that we do honor their commitments. And we have not had difficulty getting people to talk to us, and we've had nobody withdraw their consent. So when we look at the various health partners, this is who we meet with. So we're meeting with physicians, nurse practitioners, midwives, health administrators, First Nations. We have met with mayors, fire chiefs, paramedics, some of the nonprofit organizations. It all depends on who's in the community. And we get to these people by, the sampling has been to go out to people whose emails and things are public or phone numbers are public. We reach out directly to them, ask them if they want to participate, and if there's other people they feel would be good people. So we snowball sample as well as kind of purposely sample. And during the meetings, and these, this is not pure research meetings. We're not just going in to do research interviews. We're going to build relationships. We're going to listen. We're going to provide information around different programs and things like that. So we do meet with each of the partner groups separately, and then we try and bring them together. And so sometimes we bring all these groups together for an hour or two, maybe over a meal or something like that. And sometimes it's the first time they've all got in the room together. And some of those conversations are absolutely fascinating. So this is the process that Crystal and Erica have designed about how we get hold of these people. I've mentioned the email and the phone. Then we go to the community. Now, who goes? So think about it. 201 communities to visit. It takes 2 or 3 days to do a community visit. So one site lead goes, and that's usually a rural physician. We've got 1 or 2 who are not. We've got a number of trained site visitors, and they become the lead visitors. And the way they were trained was we held a training workshop, went through the concepts of appreciative inquiry around the health partnership programs, and how to interview, how to switch on the microphone, and all these different things. And we also we developed a semi-structured interview guide, which has been refined, first of all, in 4 pilot visits and then iteratively, and that's what is used. We're now using one which is pretty well the same for most of the different groups. And along with that person is one of the coordinator staff. So Erica has been on visits, Crystal has been on visits, and usually these 2 people go along, and the coordinator is the one that sets the visit up. It can take 6 months to set a visit up to get all the people together on the 2 or 3 days. So these are quite intense visits, but it also gives, as one gets to walk around the communities, gets to meet people, go to the First Nations communities which may be nearby, visit the hospital and the healthcare facilities. So you get a very deep feel for the community. And we've been in mayor's offices and all over the place. And mostly, everyone is very welcoming. So that's kind of how it works. And then all the data then goes back and is transcribed. Occasionally, we'll take guests with us. So they may be members of the JSC. We've had people from different organizations like the Doctors of BC. We've had people from government coming with us. And all of this is to help them expand their understanding of rural healthcare. So part of the advocacy is also getting people out into rural communities, because if you haven't experienced something, you often don't understand it. So I've mentioned this part of it. And Stuart, how many trained visitors do we have now? Or Erica? Stuart?
Oh, we have 20, Dave.
20? Yeah, so there you go. So and we're getting consistency in the data that's coming back. So that's my backyard, just in case you're wondering. Not now, a couple of weeks ago. And it wasn't me that took the photograph. That was taken on a little trail cam we have hanging off the back of the house. So because of the number of people, we're collecting either through group interviews or individual interviews. And I've mentioned the material goes back to the communities. And I've mentioned that we get everything transcribed and then loaded into NVivo. Hello, I can't get my slide to move. What's going on here? Oh, there we go. Okay. Slight slowing of the internet synapses there. So all the data is qualitative, and we're using a content analysis. And Erica, do you want to explain to people exactly how you went about doing this and how you developed the coding and the code book and things like that?
Sure, thanks, Dave. I can talk about that a little bit. So we originally had what's called a code book, which was pre-established beforehand. We ultimately decided not to use it, and we decided we wanted the data to really, the data to be reflected in all the different codes that were coming up. So The codebook was created by reading all of the transcripts and coding every single sentence in each interview, and from that patterns would start to emerge. As these patterns starting to emerge, you could start to create codes, and over time this is what actually created the code book. And this project is iterative, including the data, so the code book does still change slightly. In the beginning it would change quite a bit depending on what kind of information we were gathering. So primary cycle coding is kind of what we started with, and throughout time it's been content analysis or thematic analysis, where we try to capture these themes through that process. We use a qualitative software analysis program called NVivo, and that really helps to organize the huge amount of data that we have and that we gather. There are certain features you can use with NVivo, but yeah, it's been an excellent program for us to use so far. And as I mentioned before, this has been an iterative process, so themes are constantly reviewed and they're refined over time as we continue to collect data.
Yeah, and Erica, I mean, the other qualitative researchers around here must be thinking, this is over 1,000 interviews, this is hours of how did you manage to handle all that stuff? And I think you've lived and breathed these texts for the last year or two, haven't you?
I have, yeah. It's almost going on 3 years of of working on all the data coming in, and it's certainly you know, important to take breaks here and there for sure. And but it's all very interesting. And you know, while one community, you know, they say one rural community is one rural community, and certainly there are important differences between communities, there are lots of similarities too. So being able to code all the interviews and use NVivo to help collect all the data and collect all the themes has been really important and exciting.
Yeah, and you know, we also have another analyst as well. So in terms of rigor, it's been important to have some of the text analyzed independently so that we can reach agreement on what the codes are. And all of us as a team get together and talk about them and think about them anyway. So we put in some things to try and make sure that we're as accurate as possible. But you can imagine that the data's, you would think the data would be pretty well saturated by now, and in many ways it is, but we still always get little surprises.
Dave, there's another question in the chat from Julia Bickford. I'll just read it out to you. And I think, sorry, I had to just step out for the kids there, but I don't think this one has been answered. Do you have ethics approval to do a secondary analyses on these data sets? There's a lot of data here that could be explored in many different ways.
Thanks, Julia, and nice to hear from you. Yes, we've actually just been having this conversation around secondary analysis, and I think as long as the analysis is one which is within the framework of the current ethics approval, we can easily do a secondary analysis because a lot of the data is aggregated and anonymized. And it's also quite easy, if there's a very specific question, to either make an amendment of our ethics approval or ask for a very specific approval for a specific secondary analysis. And the example we have right now is dealing with whether we're going to add in some questions around racism to the visitors. And Crystal, I think you've been dealing with ethics on this one, have you?
Yeah, Dave, I literally just submitted our amendment, and so we have kind of considered the site visitors and our staff, our admin leads, as identified a new partner group and becoming participants themselves. So we do have a separate meeting guide asking some cultural safety questions on their overarching perspectives, because they do have insights from meeting individually and then seeing if those views align. So we just want to get their perspectives on that. So yeah, that's a new sort of element that we've added in.
Yeah, and while I've got you talking, Crystal, You've been instrumental in developing the processes for actually setting the visits up. Are there any insights you want to give others about some of the challenges you've had there?
I feel like I can go on forever with that. Obviously, as you can imagine, small rural communities, everyone is quite time constrained, and we don't want to add any added pressures, especially with First Nations communities being over engaged. So kind of finding that balance and sort of posing it as an opportunity for them to come together is something that we've found really useful when we are reaching out. Yeah, just and I know, like, as you mentioned, we only have a short time period, but I think that communities really appreciate even just the act of us going out there to visit their community, so that we're getting the context of how rural they are and what they face every day. So they've been really appreciative of that, and once they understand that we're coming out to them, they are a bit more committed to meeting with us.
Great, good, thank you. So I hope that answers the question, Julia. We have lots of data, and secondary analysis is possible, and we have had others asking us if they can have access to the data. We haven't actually granted any yet, because we would want to be very clear about what they wanted to do with it and things like that. At the moment, we're content to be analysing it to get the first broad picture of what's going on. So if I can get... My slides are frozen again. I don't know why they do that. Let's try this one. There we go. So in terms of the content analysis and what's been coming out, here's just a sense of some of the codes coming through. And these, if you look at them, are important things from the perspective of the community. So support's a big issue around workplace, collaboration, connections, those kind of things. Transportation, those of you working in rural areas know that transportation is a really hot button, particularly emergency transportation, and particularly if you live near the Alberta border. So we have hundreds of stories about transport disasters. One thing that really surprised me was how many of our rural communities, population increase is causing problems for them. You have the assumption that all rural communities are shrinking. That's not true in British Columbia. And lots of them are telling us, they've got itinerant populations coming in, they've got lots of people retiring there, and now with COVID, everyone's trying to escape the city. So they're now dealing with populations that are going beyond their ability to provide healthcare and things. We've been gathering successful initiatives. This is something that kept coming up again. We want to... Here's our successful initiative. We want others to know about it. We want to know what others are doing out there. We've gathered a lot of data around, the whole conversation about scope of practice and workloads. Health authorities and relationships with them are a very common theme coming through the data. And remember, we're going in asking open-ended questions. These are the things that just come up. And finances, services that are falling apart or needed. Maternity care keeps coming into this area. Patient capacity, the attachment of patients and how do we deal with them. And apart from initiatives, other solutions that people are working on. So these are kind of the categories coming out. But through all this data, as we looked at it and interpreted it, there are three themes that run through everything, which combine together, really enhance the ability to deliver good healthcare in a community. And these are relationships, autonomy, and change over time. I want to spend a little bit of time with these because they're complex. So the whole idea of relationships is, what's the relationships like between the healthcare providers in the community, between the healthcare providers and the community, and within the community, and also the relationships externally. So are there good supports from health authority? Are there good supports from specialist services? So all these different things coming together with good relationships enhance healthcare and enhance recruitment and retention potential. Linked to this is the concept of autonomy. so many communities talked about autonomy. And what they meant by that was, we know what our problems are, we know how to solve them, but we need these things to be able to solve them. And please, Victoria, don't tell us what to do, because your ideas don't work very well. And so a lot of plea for some degree of independence to focus on priorities and how they solve them within communities. Now, there's a corollary to autonomy, because if you think about autonomy and you've got issues like physician power to deal with, autonomy exercised on its own can actually be quite destructive. It can break relationships and all other things. But autonomy exercised within an agreed framework, say, for example, the administrators and the health authority are saying, okay, here's the boundaries that you can play within, and how you play within there is entirely up to you. How you sort your rotations out, how you sort your on-call out, you just do that. But this is the goals we're all aiming together. So autonomy exercised within a direction that everyone is agreed on works extremely well, helps recruitment, helps pride, and all these other things. So they wave through, they weave in and out through the data, but they bring it all together. And the other thing you'll all be aware about in rural areas is about change, and change is always happening. So the relationships and the autonomy help small communities adapt when things change. In some places, you just need one medical office administrator to leave the community, and suddenly all the services fall apart for 6 months. They're so vulnerable that way. Now we've got COVID, we've got lots of people coming in. There's all sorts of different things happening. So change is normal, and change is always happening, sometimes for the good and sometimes for the better. And so we have to help think how we can help these communities through the concept of good relationships and, as I say, a negotiated autonomy, how they can adapt to these changes. So in terms of the overall findings, these are critically important ones. The other themes I'll come back to about how we're handling them. So in a project this size, knowledge translation is critical. And you can't wait till the publications come, because everything's changed by that point. So we do reports. So the JSC reports go to the JSC on a regular basis every 6 months. And what we do is we pick a theme and we share it. And we tend to pick something that's topical. So for example, one of the very first ones we did was transport. And we were able to bring to the discussion on emergency transport what was going, what the issues coming from the communities were. And these were in the form of stories. And you can imagine the kind of stories of, not being able to get somebody out of here and the ambulance not turning up and all this kind of stuff. And we've oodles of these. Transport has been something that the RCCBC has been working on in partnership. So there's a partnership table looking at rural transport. And we were able to bring to that partnership table the data from the site visits. And the other thing that came along, the pandemic came along, and suddenly the pandemic has taken the lid off a lot of the inherent problems in rural health, and emergency transport and other transport is one of them. And so there has been a significant amount of movement in the last little while on transport. And you probably heard that the government had made more resources available and all these other things. So we're feeling a bit optimistic that things are beginning to move in that area. And part of it, we think, maybe the four of us are biased, but we think actually the data we collected from the communities actually made BC Emergency Services and the government and others suddenly sit up and realize, yeah, people are not just whining, this is a problem. So that's how we're using the data. It's to try and advocate for different things. So we can do very specialized reports, and transport was one of them. And we will pick another one around, we're looking at the whole issue of racism now. We've done one on CPD, and we've done one on the rural surgical networks. There's lots of different areas we can focus on, but we have picked the biggest emerging themes, done a report on them, and taken them to the JSC to say, here's a big issue in the rural areas you need to think about, and can the programs be adapted? So I think we're beginning to see some movement in these areas. The other thing we've done is we do community reports, and everyone that participates, we send these reports to them. And they're also publicly available. So any of you can go onto the RCCBC website, look at the site visits page, go and click on community reports and see the kind of stuff that gets sent back to the community. So we're trying very hard not just to bring stuff, we're trying to synthesize it and then send it back. And so I think that's a really critical point of what we do. Stuart, do you want to make a comment on where you feel we've made the biggest difference with our data so far?
Yeah, thanks, Dave. I think you've actually nailed it with the transport issue, and there's absolutely no doubt in my mind from comments by Trina Larson-Souls, who sits on with the government on transport, and others who've dealt at that level, that the evidence that we presented was compelling in terms of people, particularly with the loss of greyhound, people being very isolated in rural areas for all forms of medical transport, not just emergency, but attending your oncology visits, transport post-operatively, and so on. And that seems to have caused some significant changes where they have put more ambulances out into rural areas. Our greatest concern, like all of the other changes that have happened with COVID, is to whether they'll be sustained.
Yeah, and you know, some of the patients can be absolutely stunning around some of their descriptions of the transport issues. And you know, I still remember a graphic description from a patient of having to go in a Greyhound bus for a colonoscopy when he was full of laxatives, and you can just imagine what that would be like. This is the reality every day. So thanks, Stuart. Sarah, do we have any questions that I've missed so far?
Your team has been amazing. They're answering some of the questions that are coming into the chat. So I think we're up to date. If I have missed any back there, then just send it again and I'll interrupt Dave.
And if any of you have any, just send them in. So the other thing that Crystal and Eric have been working on is the site innovations. What's the exciting things happening in rural, and what can we disseminate? So there is now a website with the site innovations on it. There's a YouTube link here. And Eric, so Crystal, do you want to tell us about the website? Is it all up and running now, and can people access it?
Yeah, we just launched it in at September. So what we found is a lot of participants were wanting to learn more about what other communities were doing to address similar healthcare challenges. And we were also just hearing so many innovative ways of working, whether it was like an initiative, a new model, or even just like a workaround in their practice. So we've taken all of the feedback and taken that out of an in vivo, and we got an additional consent approval going back to the initial innovators, and so that they could display their name, their contact information, and their community. And basically we categorize them, by different healthcare challenges. And so you can do a word search or go by category to find all these different innovations. And it was a way to hopefully create almost like an informal community of practice so that communities can reach out directly to one another. And another piece that we've added was having a live innovations concierge, not live on the website, but an actual person who you can email. And if you want to know more about an innovation or get connected, because not all of the innovations up there have contact details yet. But we have Tracy on our team who's happy to help connect and think a bit more broadly of what other innovations can help other communities.
Yeah, that's great. And so yeah, I think that underlines one of the things we're trying to do with this project, which is to be completely transparent and to try and make as much available as we can from what we gather so that people can use it in different ways that work for them, because the real purpose here is rural advocacy. And here's an example of the kind of innovations. And it's interesting that this comes up from a community at a time when everyone's talking about defunding the police. But here's one where in a community, police calls dropped 40% after a social worker was hired. And that led to the permanent creation of the position. So this is the kind of stuff that you will find out there. And there's a little bit on the bottom corner of this slide about what's included in an innovation. So if you're interested, you can, I think they again can be accessed through our innovations website. So that's kind of the end of the formal presentation. And if you're wondering where that is, that's just 100 kilometers outside of Prince George, the tiny little bear in the corner there. So Stuart, Erica, Crystal, have I missed anything? Anything you want to add?
Thanks, Dave. No, I think you've covered that very nicely. Just 3 points that I noted while you were talking, which might be of interest. As a result of the ethics clearance, we go in and we're very clear to the interviewees that they are completely protected through anonymization and aggregation of the information. And what it's done is to produce some extraordinary interviews where people have just unloaded, and comments by people in health provider situations, administrative situations, just saying that it's been so good to be able to speak openly about their concerns. Thank you for coming. It's something that we hear again and again. And we found that very interesting. In terms of Dave's comments about the population changes in rural, and this is public data, so we can put it out there, one of the most astounding places was in Vermeer, where with a base population of 340, they rise to 30,000 people at the height of summer in that community. So that's a 100-fold increase in their population that the healthcare services have to deal with. And finally, in terms of innovations, I think for me, one of the most interesting innovations has been in Hope, and again, this is public, where the physicians there went to the health authority, Fraser Health Authority, and advocated for some autonomy in the way that they deal with their own local problems. And to the health authority's huge credit, they said, fine, we'll give you $500,000 a year, and you, together with your surrounding communities of Agassiz and Seabird Island, can decide how you would best spend that money to address the priorities that you determine are important to you. And it has been an amazing success to the extent that the health authority has continued to fund it annually. The changes that they've brought in have been quite extraordinary. And it's a model which we hope will spread to other areas around the province. So a couple of interesting things. There have been many, many others like this. Thanks.
Yeah, it has been absolutely fascinating to learn about our communities. And the one of the ones I remember, Stuart, is the one not far from where you live, down in the Soyuz, speaking to folks down there and realizing that they have 2,000 snowbirds there each winter, or they did up till pandemic. And what struck me was these are the snowbirds that are too sick to be able to get insurance in America. So they come from the prairies to a Soyuz, which must be such a challenge for the physicians there. Yeah. So, Erica, Crystal, do you want to add anything? I see Margot asking something. Margot, the short answer to that is we're trying to write this up right now. And that's as you can imagine, is quite a challenge, writing up both the process and these kind of early results. We can't find anywhere else in the world that's done such an extensive community engagement process. And if you look at the community engagement literature, what we've seen of it is there's lots of stuff going on. Often it's focused on one or two communities to try and fix something. And often it's focused on very specific conditions. Let's go and fix the left toenail surgery in such and such a community, that kind of stuff. So this is the first one we've been able to find with such a big engagement, collecting data rigorously, very open-ended. When somebody is asking you what the questions are, we just look for basically open-ended questions. What's going well here? What's your challenges? And all this stuff has come from there. And I'm just not aware of such a big project anywhere else. And when you speak to people, they think, you guys are nuts. How can you handle all this stuff? But it's a great team. They're doing a fabulous job. And it just seems to be such a rewarding thing to be doing right now.
This is amazing work, Dave. We have 30 people, 30 participants. So I just want to give everyone just a second if they have any questions or they want to type into the chat before we let you go. If anybody has any questions, feel free to put them in the chat now. Maybe I could just ask a sort of just a small question, really. Given it sounds like the communities are really so thankful for you coming, and you talked about how things can change so quickly in rural communities. So is this something that RCCBC, in collaboration with your team or others, plans to continue so that you can revisit communities on a regular or a semi-regular basis?
So maybe I'll dive in there, Dave.
Stuart.
Ray Markham, who is leading the Rural Coordination Centre with Leslie Carty, put this forward originally as a one-off to establish the funding for it. But at the same time, hoped it would go on, and very quickly as we got going, realized that the real value of this would be to keep doing it going forward. We had hoped to get through 201 rural communities in about 3 to 3.5 years. COVID has completely kiboshed that. And but I think as we get going, 3 years would be a reasonable repetition time. And so, yes, we are now looking at this with a view to doing it again in the future and keeping it going. And, the change over time issue that we've picked up is a very big thing for all of healthcare in British Columbia. But certainly in the rural areas, it seems to be a major thing in terms of community changing size, services. A lot of the services in a rural community are often serendipitously provided by the RCMP's officer's spouse is trained in something, and so they bring that service for a period of time and then it disappears again. So change in these small communities is quite large and can have a very big impact on the citizens there. So yes, we do hope to keep going. Sorry, long answer.
That's great. I think the longitudinal look, I don't know how you manage all that data, but it would be so interesting. We're getting a few questions here. Oh, sorry, Dave, did you want to add to that?
I was just looking at Andrea's question about
great question.
What you need from the academic community. And that's a really good question, Andrea, and I'm not sure that I can answer it straight off because we've tried to partner that. I'm there because Stuart partners with academia to try and help this thing along. But there's so much data, Stuart. Have you thoughts about what help we might need in the future about publicizing this better?
Yeah, well, it's not just yourself, Dave. Martha, who's here as well, has been very kind in helping us as well. I think right from the get-go, my greatest hope was with this enormous amount of information coming in, that we could actually produce some tangible results out of this and make it a useful study. rather than just a dusty report sitting on a shelf somewhere. And we have felt very constrained by the ethics in some ways, but in other ways, as I've mentioned, by reassuring the interviewees that they are so well protected, they've shared an extraordinary amount with us. So we're caught in this unusual position. Going forward, it would be helpful to have advice as to how we can better translate the information we've collected into tangible change.
I think the other thing that we've been able to do is, until a few years ago, the JSC was abreacted to the concept of research. And this is, A, they supported this, but B, I think they now value the data coming in because it's really beginning to help them in their advocacy. So, and I'm also sensing that I sit on the provincial committee for COVID research advice to the government. And I'm certainly beginning to sense that people are beginning to understand that rural areas have been actually underfunded in terms of research, and we need to get our act together around about it. So I think there may be opportunities for the academics here to be thinking, how can we get rural research profiled better, and how can we get better funded? And I know that Michael Smith are now beginning to think, how do we support the rural research better? So while we might need your help about how we publish this stuff, or as things come up, we may need more help even just to know to analyze and reanalyze stuff and have a think about it. You can imagine how much is there. I think we're always amenable to people who've got ideas that we might be able to support, but we also may be able to begin to help people think about that this is how you can try and navigate the system to get your own research funded. And very much, I'm seeing where this is different. This is not a research question that we're burning to fix. This is trying to find out what's going on to help communities advocate and fix their own problems.
Another aspect of this has been to reduce or limit the interviews to 1 hour, recognizing that all the people we're talking to are busy in their own right. And it's been very interesting that seems to have been much appreciated. It's allowed us to fit meetings into lunchtimes and morning and evenings as well, without too much pushback. In fact, really very little pushback indeed from anyone. So we try to minimize that. I had a most interesting discussion with Stefan Grzybowski, who many of you will know, I'm sure, who severely criticized me at the beginning. He said, if you're doing proper qualitative research, you don't limit the time. You've got to allow people to talk about their passion, and you don't limit the direction that they're going in. And I pushed back at that, and I said, I understand, but there is such a wealth of information that we're trying to gather that we do need to guide them or to prod them to provide information in certain areas. And out of this has grown our semi-structured interview guide. And going forward, we have the ability to change that, so that if researchers came along and said, I've seen the mental health issue come up in the chat now, and yes, there's a lot of information on that. It's a hugely sought after service right across the province. So, if we were to do the second round of the communities, we could, for example, formulate a number of questions around that, which might lead to change in mental health services, for example.
Another couple of, and thanks for those questions, Yasmin. I don't think there's a mayor that we've spoken to that hasn't put mental health and addictions and not enough housing top of the list of issues. So there's stuff there. Erin, you were asking about the end for the different groups interviewed. We actually do have that data. It's not public yet because it's in the publication we're trying to figure out how to write. With a bit of luck, it'll be public in the not too distant future. But we're always happy to share. Catherine's asking, because you guys are asking great questions, how are you going to change your findings? with having to communicate virtually. And interestingly enough, we were doing so much virtual communication even pre-COVID that a lot of the times some of the stuff we do is done virtually. So we really miss out not going to a community in person. You don't get the feel for it. And you've done a couple of virtual ones, I think, Stuart, and I don't think you liked them, did you?
No, it has a very different feel. And for the people we spoke to as well, they commented on this. But Dave, you nailed it when you were saying when we go into a community and we actually arrive in some of these more remote communities, the very fact that we're standing on their front doorstep and we're there in their community means that we've taken the flight to the nearest center, driven to the nearest ferry, crossed the ferry and got to the community. We know what it's like now if a patient gets sick and has to be shipped. And so they greet us very, very warmly, and there's a feeling that we get it. We understand what they're talking about by physically being in their community.
Yeah.
There was a question from Julia. Oh, but Crystal, it looks like Crystal's answered there about patients being involved as participants. Did you want to add anything, Dave, or has that been answered?
Yeah, Crystal's answered that well, that we don't specifically seek patients, but we end up talking to people who are patients. And so some of the community groups and people through the snowball sampling that turn up are people who might come from the local chamber of commerce. We meet all sorts of people. They are users of the health service. And so I think there's a difference between, in my mind now, about patients and users. Because some of the people who use it are not sick, but they've got relatives who are sick and all these other things. So I think we get the perspective that way, but we've not specifically gone in to look at it, because the whole purpose of this was how do we advocate for improving health service? But it's a good question, and thank you for that.
And really raises the issue, Dave, that in small rural communities, it doesn't matter whether you're the mayor or the chief or anyone else, you are a user of the healthcare system in that community and a de facto patient.
Yeah, thanks, Margot. Off you go, and thanks for those nice words.
So I think we're seeing the questions come to a little bit of a slow. We usually go between about an hour and a half. So it looks like you're just perfect timing there, Dave. There's been a huge amount of interest in your work been generated, I think, here today. We've had over 30 participants for most of the session today. Just an incredible amount of work, so many stories, so much data, and I think so much potential to drive change. So congratulations to you and your team, and thank you for sharing with us today.
Thanks for asking us. It's been a great pleasure to be with you. And I just have to thank Crystal and Erica so much for their efforts. And they did the first draft of the PowerPoint. They're way better at it than me, and I just kind of messed it around a bit. So thanks for all your help, the two of you.
Is it your job, just Dave, to get the pictures on the top of the mountains?
Well, I always, people who get bored of the text, it's always nice to add in one or two things. Yeah, I took all those photographs.
I'm just teasing you. So I also want to, just before we all leave, I just want to remind you that our next seminar series is on November 19th, and we'll be hearing from Annie Duchesne, who is, I don't want to say new, she's been here for a couple of years now, but a newer faculty member at UMBC. So we're really excited to hear from her. Rachel, have I missed anything, or is there anything else you want to say in close?
No, just thank you everyone for the great discussion today. I think this is probably one of our most robust discussion times we've had in this series. So I just thank Dave and the RCCDC team for being here today and letting us ask our questions and having an open conversation.
Yeah, I agree. Thank you, everyone.
And thanks so much, everybody. It's so nice. You know, one of the problems with COVID is we don't get to see anybody anymore. And it's so nice to see so many people here that we would have loved to have met in person today.
That's wonderful. Thank you so much. Oh, and there's just a little correction I have here. I apologize, Bree. I should have known. So she just noted here that Anita Shaw will be speaking with Annie at next month's seminar as well. So keep an eye out in your inboxes for that advertisement. Thanks again, Dave, Crystal, and team. And yeah, really wonderful to see so many people come out today. Thanks.
Thanks very much then.
Thank you. Bye-bye.
Everyone.
Bye.